We start the National Symposium on Glaucoma. I invite our chairpersons, Dr. Ramakrishnan, Dr. L. Vijaya, Dr. Pandav, Dr. Pradeep Vyas, Dr. Harsh Kumar, Dr. Chandrima Paul, Dr. Mayuri Kumar to be on the dais. And I myself, Dr. Amit Porwal, will be the moderator of this session. So as a tradition, we'll maintain the quorum, we'll maintain the time limit. We'll have 2 talks on either side. So one speaker is presenting, the other speaker in the order will be ready with his talk on the next podium. And we won't waste much time, and we'll take the discussion after all the talks are over, so that we don't overshoot like other sessions have done. Yeah. So I invite Dr. Sushmita Kaushik to start her first talk on current and future trends in applications of angle imaging. So the whole symposium is on cutting edge technology, and we have the experts in the field who are going to discuss what is happening globally. Madam, be careful. And I request Dr. Satyan to be ready with his talk on the other podium also.
Is the time 3 minutes?
So time is 10 minutes for each talk. So the timer audiovisual will have one buzz at 9 minutes and the last final buzz at 10 minutes.
Well, good morning. And at the outset, I thank Dr. Amit, the GSI and AIOS for the opportunity to kickstart the National Symposium. Can I have my slides up, please? Right, so we start with current and future trends in the application of angle imaging. There are no financial disclosures. So why do you need to image the angle? You need to see the angle to visualize and take a picture to diagnose. That's one. That's an essential part of your assessment. See the aqueous drainage pathway and possible causes of occlusion. Diagnose an occludable angle is of utmost importance. And then it's important to demonstrate what you see, and it's also important to record what you see for future. So quantitative angle assessment is a possible clinical management pointer which demonstrates the efficacy of treatment. Now, gonioscopy is the gold standard against which all anterior segment devices are evaluated, be it the UBM, be it the AIOC and even the newer ones. But with ease, cost and feasibility, there's really no debate. There's no debate of doing a gonioscopy versus the cumbersome process of doing a UBM and the cost of acquiring an AIOC image. So we need to be really careful about what is it that we want it for and why is it required. If at all there's a debate, it would be in primary angle closure disease, but we know that Asians comprise a large part of the world's burden of angle closure, and 91% of people who are bilaterally blind have primary angle closure glaucoma. So we went ahead thinking that the UBM would be a better objective tool because gonioscopy is subjective. However, when we did that and we did a head-to-head blinded comparison of the evaluation of the angle by UBM and gonioscopy, actually to diagnose a primary angle closure or to diagnose whether an angle is open or closed does not require a UBM. So we don't need imaging to tell us that. Is there a utility in plateau iris, which are the glaucomas where LI doesn't work too well? A double hump sign has been observed on indentation gonioscopy, and somebody has actually looked at plateau iris imaged by gonioscopy as well as by the UBM, and they found no difference in diagnosing plateau iris. Aage nahi ja raha bhai. Okay. So is there a utility in trauma or PDS? Again, angle recession and cyclodialysis clefts are demonstrated well, but you don't need imaging for that. What about pigment dispersion? You can very well see the concave iris and pigmentation, which you don't need a UBM for. So do I need a UBM really to tell me all this? And how would quantitative imaging, for that matter, show up a subtle Sampaulosis line or a painted trabecular meshwork, or even blood in Schlemm's canal, broad-based pass in uveitis? These are just some examples of how important gonioscopy really is, or even iris processes Naxenfeld. So the point is, we don't need machines to do a lot of the angle work that we as clinicians can do. Going on to iris nodules in Cogan-Rees, peripheral anterior synechiae in Chandler's, neovascular glaucoma, emulsified silicone oil in the angle after PPV. All these things are what we do day in and day out in our clinics and give answers to vexed questions that we can't answer. Now let's see the evidence. So the big question is angle imaging? I'm sorry, it's a bit of a busy slide, but if I just want you to concentrate on one, the big question is it useful for screening? 2,000 patients were screened for narrow angles using anterior chamber analyzer, the IOL master and the ASOCT, and gonioscopy was a reference standard. So the sensitivity and specificity were not too great, and the low specificity limited its usefulness in screening for narrow angles. So that was out. The idea that you could take out a machine into the community, put them on it and screen for angle closure was not true. The other study decided to detect PACS in 425 eyes of 431 subjects who were diagnosed by gonioscopy. And they actually used Van Herrick, they used ASOCT, and they used the Pentacam. But the sensitivity and specificity was not great either. So none of the tests evaluated achieved the combination required for population screening. So it's not too great to diagnose angle closure in the population either. Is it observer independent? Now that's another question. The scleral spur could not be detected in approximately 30% of angle closure of the anterior chamber angle quadrants, especially in the superior and inferior. So 1/3 of people, if you cannot even detect the scleral spur, you're not going to be able to image the angle accurately. And then there was this interesting study about the comparison of the Visante, the Cirrus ASOCT and gonioscopy, because the debate just goes on and on and on as to why not use an ASOCT to detect angle closure. And it was detected in 18, 16 and 48% of quadrants, but the scleral spur was detected in only 56%. So again, it's not so operator independent. You do require some expertise to accurately detect where the scleral spur is. The recent developments has a swept source OCT, which gives us circumferential assessment of the anterior chamber angle. It's a beautiful picture that you get with the cassia. So there's no question that image-wise, it is really, really nice. I would say that it's important to tell a patient and show him, if you have the machine, it's nice to have it on your desktop and say, see, you have an angle like this, and then you do an LI and say, see, your angle has become like that. But whether you require it for clinical practice that much is debatable. Good agreement with gonioscopy always. The next thing that is coming in with the cassia, which is in development, is deep learning. Artificial intelligence classifiers are in the pipeline to be developed to determine the presence of angle closure on the swept source OCT. So we need to look at whether that AI is as good as the actual eye and not the artificial one. So we'll have to wait for that. Now just a quick thing of what the experts say. The WGA consensus on ACG says, and I quote, gonioscopy is indispensable to the diagnosis and management of all forms of glaucoma, and anterior segment imaging devices may augment the evaluation, but their place in clinical practice needs to be determined. So that's a consensus statement from the World Glaucoma Association. Don't get me wrong. Imaging is indispensable in situations where gonioscopy does not give you the answer, but it's not a replacement. They're both complementary. We've used it n number of times for the angle, for places where we can't see the anterior chamber. Just an interesting thing while making this talk, there are something now being developed. It's not commercially available as yet, but they're being developed as goniophotographic systems. They've actually called it the GPS. So the GPS of the angle, if you say. There are two commercially available devices, not available here, but as prototypes. The iCam on the Clarity Medical System, CA-US, actually has a lens which they have now started marketing for evaluating the angle. Now imagine buying a ret cam and then investing in another lens only to be able to put it on the eye and show an angle. So that's a little, to me, it's really not required that much. The other is the NGS-1, which is called an automatic gonioscope. That's been developed. The prototype is available from NIDEC. There's a gonio pen and there's an Axicon lens, and they've called it assisted gonioscopy. So it's like a pen, and as you can see, that's the demonstration from the flyer. The patient just sits there, looks into the machine, the The gentleman puts a pen on the eye and voila, you get an image like the one in the center. Much like a gonioscope, much like a gonio image, but anyway, it's there to demonstrate and record it. Most of them require several images to select the best, and this is what the flyer says. So you can imagine if the seller is telling you that you're going to require multiple images, it's low resolution, and NGS1 performs this operation automatically. So I'd like to conclude by saying gonioscopy remains an indispensable tool. So when we are talking of imaging an angle, it means doing a gonioscopy and taking a photograph, even now. Imaging devices are not without their limitations. They may be revolutionizing angle closure assessment later, but clinical dynamic indentation gonioscopy remains the current reference standard, and imaging devices augment clinical practice and are useful tools for research. Thank you.
Thank you, Dr. Sushmita. So as decided, we'll take the questions at the end of all the talks. So now I invite Dr. Satyan for his talk on role of advancements in perimetry in today's practice.
Yeah. Thank you, Amit. Very good morning to all of you. I'll just touch upon what are the newer advances in the already existing perimeters, and also what are the newer type of perimeters available in today's practice. So looking at the Octopus, what are the software upgrades is, one is on the optic nerve head projection analysis. If you have the Pro version, then you can always see all these things. It is just how we can correlate the anatomical changes, where exactly is going on. We can look at this optic nerve head projection analysis, and we can look for the changes over that place. And not only on the optic nerve head, it has also given the macular map closer to the GCL, how we map the GCL in the OCT pictures. So that's how the macular map is done. These is all kind of an extrapolated data. Then you have the serial analysis, though it is already been existing, but there is a new software upgrade where we can really match. If you want to delete some of that, we can easily delete. The software upgrade has been done. And also when you're looking at the progression analysis, especially on the polar and cluster analysis, they are given the trend analysis for the polar and cluster analysis, which is again an advancement in the software. And also just have a look at this portion, the last portion here. We can always select. This one thing which is good in Octopus is we can just select and deselect whichever you feel is not done good. So if you have selected all this, then you can see that as though it's showing that the fields is becoming better. But then you see in this graph, I have selected a different one, and you can obviously see this one is something similar to the theta fast. So I have just deselected, and then you see the 3-1. These are the 3 are the G dynamic. Then you can really see what exactly is the progression going on in this. So the other advantage is you have done a 30-2 program or G dynamic program, and if you want to shift it to 10-2, then you just switch it to this mode, and then you can immediately see that how the 10-2 will appear to be. So you don't have to really do a separate 10-2 in this Octopus. Then the other one is something called as a summation. We all know that the binocular visual field how it has to be, but we really don't see how it will be. So this is the binocular summation. From this we can understand how the patient probably will have the field functionality of the field will be for them. So then other test is introduced is the ocular motility test. If you have a patient with say 6th nerve palsy or 3rd nerve palsy, you can always examine the patient's ocular motility completely than what we do with our other charts. So this is other upgrade in the Octopus perimetry. Then looking at the Melbourne rapid visual fields developed by the AppView Technologies. This is a newer perimetry where the patient can do it at home. This has been tested against the basically on the HFA pattern, iPad based test, and you can see that it is a portable device. HFA 24-2 is being clinically validated based on that. Then they have so you can see that this is how the test is being done. I think many of you would have just experienced this in at least in the conference venue. I think they have one here. So the patient has to just touch the screen. They have shown it here. So they just touch it and then it gets recorded, and then you can see the pictures. It is something similar to the HFA pattern. This is how the MRF will appear to be, though it is a little bit different, but it is the results seems to be the same when you look at the ROC curve and also the retest variability also. It is shown to be something correlating very well with the Humphreys. So that is, and all the other tests also available, like a glaucoma pattern you can do, neurological test, macular, and the diabetic functions, everything we can do in this. And coming to the Humphreys, what is a new upgrade in the Humphreys is one is on the CETA Faster 24-2 program. Then you have a 24-2C where you have the central points, the number of points that have increased so that we don't miss any of the points. And then they have the review software, which is something similar to the Octopus iSuite software, and the automated patient alignment. So these are the newer introductions, what they have done. So they say that the CETA Faster is much more faster than the existing CETA Fast program, so which has saved the patient's time and also our time as well. So this is the liquid lens where you don't have to really place the trial lens anymore. But I think it is not for all minus or plus whatever. I think it is up to +3 or -3. I am not sure about that actually. So then in Octopus they already given this automatic aligning software. I think the HFA has introduced recently in their new machine. So you really don't have to keep changing the patient head. So alignment is automatically done. And the review software where you can sit in your clinic and then see with the software itself. You don't have to take all the printouts to see how the patient is doing or how the progression analysis, everything can be seen in your desktop. Coming to the next one is the AVA, that is Advanced Visual Field Analyzer. This again, it has been published by one of our consultants in IJO. So this you can just lie down, do it anywhere. So this is very comfortable. The one advantage is the nose is not covered. The patient feels quite comfortable. Wherever he feels comfortable, he can sit and do the test. And it is something similar to the Humphreys. Again, it gives you the same kind of results. The full threshold testing has been done in the LSR perimetry. And coming to the last one is there something called as a AVA, sorry, not AVA. This is the Alphase technology. I think Venkatesh is one part of the upgrading that machine, the analyzer. IVA, there are multiple analyzers have come into the market. So this is again similar to the HFA pattern. Full threshold testing has been done in the same way like others. One is it looks like more of a color coding is also done in this. And similar to that, they have the upgraded versions is Intelligent Vision Analyzer is the last upgrade they have. So these are some of the upgrades that we have in the current perimeters. I think from LVP also they have introduced one more perimetry, something similar to the HFA printouts. So these are some of the upgrades that we have currently. Probably we can have more questions. Yeah.
Thank you, Dr. Satyan. So we'll take the next talk on advancements in OCT for early diagnosis in glaucoma by Dr. Sushma Tejwani. Sorry.
So thanks, Amit, and thank you GSI and AIOS for giving me this opportunity. So we have graduated from say time domain to spectral domain and swept source OCT over a period of time, and we know as we grow ahead, the scans become faster, the acquisition techniques become better, we have better segmentation algorithms, so our accuracy increases. However, if we look at the diagnostic accuracy of any of these OCTs, they are statistically similar for diagnosing early or pre-perimetric glaucoma. We do have different types of printouts in different machines, but largely we do get RNFL thickness. These are thickness maps that you see, and you can see in a normal, the hotter colors are representing the thicker NFL and the cooler colors represent the thinner NFLs. And you get deviation maps, you can get the color-coded flags if the RNFL is abnormal. That is what we look at in RNFL analysis. And we also get this kind of Tisnett graphs and clock hour graphs where you have these yellow or red flags where the RNFL is abnormal. You can have comparisons of both the eyes. So these are green zone is 95% of the normal, and red zone is less than 1% of the normal, and this black line is what is patient's RNFL, so you can understand which area is abnormal, and similarly in the clock hours region. So that's how we can look at and have comparisons between the two eyes, the inter-eye asymmetry. These are the basic things that we get in all OCTs. However, the diagnostic parameters, the best is supposed to be RNFL thickness. Now, what further we are getting in advancements is what we keep looking at on the horizontal scans, that is ONH parameters, GCC and OCTA, about which I will talk a little later. This is a case where this is a 41-year male presented with the normal vision pressure, and on a cursory look, you can see there's an NFL defect there with a dilated disc evaluation and normal fields. And this is what is the advantage of OCT, that you can pick up pre-perimetric glaucoma. You can see a corresponding thinning in the same area where you saw the RNFL. Now, when we looked at this and treated this patient because the pressures were high on DVT, later on when we did the blue on yellow, we could find out the corresponding field effect as well. Now, optic nerve head analysis is another component that is an important part of OCT, because the scan determines the anterior surface of the RNFL and the RPE. So you can look at the rim area, nerve width at the disc, cup diameter and disc diameters, and get the quantitative analysis also, which you can have for comparisons. Recently, what we have started looking at is also the ganglion cell complex. Now, ganglion cell complex is a nerve fiber layer, ganglion cell layer and inner plexiform layer, and almost 50% of the RGC synapse in macula. So we started looking at macular GCCs, and these are also represented as thickness map as our RNFL, and deviation maps in relation to comparison with the age-related normals, and the significance map where you have the yellow and the red flags where the GCC is abnormal. So what happens there is the blue areas are representing the thinning at around 20 to 30%. So this is how a normal GCC would look like, and this is the deviation map, so you don't see any flag signs. You also get a parameter called focal loss volume, which can tell you about the particular area or a focal defect on macular GCC, and this is how a glaucoma GCC would look like. So you can actually correlate it with the fields or the RNFL thickness. I will give you some examples. Like this is a case where you can see there are NFL defects on the right eye. In the left eye, also some areas that we can look at which appear darker. Now, when you look at the classical RNFL analysis, you can clearly see that corresponding areas are red, but the left eye, you don't see any changes on the RNFL. When you do a GCC, you can see that here you have the flag signs corresponding to both superior and inferior, and in the left eye where the RNFL was normal, the GCC has picked up that area which you were seeing as a darker area. And when we looked at the fields of this patient, so you can see the right eye, although the fields are not very reliable, right eye has a classical biarcuate with a 10-2 also, and the left eye also, if you look at the 24-2 also had superior defects, and the 10-2 also shows those points. So this is the kind of help we can get in addition in certain situations where GCC can pick up earlier than the RNFL. So that is the newer part of the OCT that we look at. Another case where you can see there is a darker area here. The RNFL shows the change, and the GCC also shows a corresponding change if you look at carefully, and the correlating with the visual fields. So this is really helpful in glaucoma as well as neurological situations where you can pick up the changes on GCC. Coming to the OCTA, which is the newer modality that we use. Now, OCTA is an angiography where the dye is not required, whereas the RBC motion itself works as a contrast to delineate the vessels. In glaucoma, what you see here is the loss of superficial vessel in optic nerve area and also in the macular area. So these are the slabs that you can order for in the optic nerve, the nerve head slab, the radial peripapillary slab, and the choroid slab. In the macular area, you can have a superficial and deep slab. Now, this is how a normal OCTA would look like. And you can also get the angioflow density in different areas in terms of quantification. If you look at a focal defect or early glaucoma, you can see there is a focal loss of the choriocapillaries there, and you can see there is a less angioflow density in a particular area, whereas a diffuse defect would look like that, where there would be an overall depression of the angioflow density, as well as the heat map shows you that. Coming to a clinical situation, now this is a patient presented to us with an acute angle closure attack, 44 pressures and classical angle closure glaucoma in one eye. So we did the PI, and after that, when we did the detailed evaluation, this is how the field looked like. The right eye had significant damage, whereas the left eye was normal. When we did the OCT RNFL here, because it was a week or two later than the PI, we could not see any of the RNFL defects because there is RNFL edema in these patients. But in these situations, OCTA can be helpful at times. So you can see the differences in the right and left eye, in the ONH area as well as the macula, which is more highlighted when you look at the heat maps, that the differences that you can see, that correlates with the damage that you see on the optic nerve. So in these situations, OCTA can be helpful and overcome certain limitations of RNFL analysis. There's another example where you see a RNFL defect and a corresponding field defect, and this is how you can pick it up on OCTA. You can see the heat map here, optic nerve as well as on the macular area, and you can see the angioflow density being reduced. So that is where the clinically OCTA can be useful. Need to keep in mind that there are certain limitations that we need to keep in mind, as it is for the RNFL, similarly for the OCTA as well as GCC. Now this is a patient which was on treatment for glaucoma. However, when we looked at the optic nerve and the visual fields, they were perfectly normal. Because the OCT showed different flag signs, as you see, yellow and red, so RNFL thinning areas in both the eyes, the patient was on treatment. However, we stopped the treatment because everything else looked clinically normal and the patient stayed all right over the 6 years follow-up that what we had without the medication. So we need to be careful about the red disease. We should not be only depending on the flag signs to look at the disease. Certain things which you can pick up on OCT, there is an advantage like this. You have a clover leaf defect and you see the OCT is normal, so that helps you prevent from unnecessary diagnosis or unnecessary management or glaucoma label for a patient. You need to also understand that there is the importance to be given to the disc size. So if you have an unusual size like this, you will have normal fields and abnormal OCT, particularly when the discs are small. That happens because we are calculating the RNFL thickness at a particular circle or a particular area. So when the disc size is different, the distance of the calculation circle from the disc margin is different, and that's how the RNFL thinning gets misrepresented because it does not match the normative database. So whenever you have a larger disc or a smaller disc, we should not be relying on the statistical analysis provided by the machine. So there are certain limitations that we need to keep in mind, not very useful in advanced glaucoma. There are certain other limitations and artifacts that can happen. I will skip that. So just to summarize, as we understand the machine, we also need to understand the limitations, the operator dependent, machine dependent, and then read the printout carefully and understand, and most importantly correlate clinically so as to label a patient. I think I'll stop there as the time is over. Okay.
Thank you, Sushma.
Thanks.
So we'll take our next talk by Dr. Sunita Dubey. She's going to talk on surgery beyond tubes and traps, and are we, India, ready for beyond these tubes and traps?
And AIOC for giving the opportunity. As we know, traditional surgeries like traps and tubes have been successfully employed for several decades. However, they may be associated with sight-threatening complications. MIGS, being mostly conjunctival sparing, avoid the complications and relative unpredictability of the conventional glaucoma surgery. If you look at this glaucoma management spectrum, MIGS were designed to bridge the gap between the medical or laser therapies and more invasive filtering surgeries in mild to moderate glaucomas, especially if the patient is undergoing cataract surgery or the patient is allergic or non-compliant to the drops or cost is a factor. In this review article by Dr. Aik Ahmed, it was summarized that the MIGS procedures offer reduction in IOP, decrease in dependence on medical glaucoma medications with an excellent safety profile, and differs from the role of more invasive glaucoma surgeries such as straps and tubes. MIGS can be classified based on their physiological mechanisms and anatomical sites of action, and we in India have been now doing all these procedures which deal with the Schlemm's canal procedures and trabeculotomies. So basic mechanisms is targeting the site of maximum resistance and increasing the outflow through the conventional pathway. Just a word about incisional versus excisional. Goniotomy, which is an incisional procedure which has been primarily used to treat congenital glaucoma, and it works very well. However, it's an incisional procedure and often leave residual leaflets and scarring, and therefore not so effective in adults. As opposed, excisional goniectomy with trabectome and KDB excises the TM completely, and it minimizes the chances of scarring and re-occlusion of the collector channels, as remaining edges of the TM are far apart, and therefore it is effective in adult patients and across severity of the disease. Now coming to trabectome, it's a stand-alone device and utilizes a controlled plasma-mediated ablation system which removes the diseased TM and inner wall of Schlemm's canal. And the advantage with this standalone system is that it incorporates irrigation and aspiration. It pressurizes the eye and thereby increasing the intraoperative visibility and maintaining the anterior chamber all the time and managing the blood reflux also. And as with any angle surgery, the position and setup of the microscope is very important. So tilt the microscope towards the surgeon and rotate the patient's head away 30 to 35 degrees to maximize the gonioscopic view. Now coming to the surgery, these surgeries are generally performed along with the cataract surgery. So after having a good view of the angle, incision 1.7 millimeters given in the clear cornea, and that probe is advanced towards the angle. The trabecular meshwork is engaged with the tip of the probe and start ablating on one side. It should go very smoothly along with the arc of the Schlemm's canal without any resistance. And you can see this white line which is suggestive of the outer wall of Schlemm's canal. And as you keep rotating the gonioscope, you can target up to 140 to 160 degrees of the angle. And then you can go ahead with your phacosurgery. And this is another case of a child. And here you can see you're performing this goniectomy, and you see the the inner wall of Schlemm's canal, and you can see the outer wall of the Schlemm's canal. So when you perform the technique properly, you see this cleft post-operatively. Now coming to Cahook dual blade, it is specifically designed for the goniectomy. I'm not getting the cut here. So, so it has a sharp tip which pierces the trabecular meshwork, and the ramp lifts and stretches the TM, as you can see in the picture, and feeds it up to the dual blade, which creates parallel incision and excises the strip of TM. And the foot plate of the device settles within the canal. So there is no collateral damage. Now the surgery is more or less similar to as I had shown in the trabectome. This is the blade. Again, you target the trabecular meshwork, and with this blade you incise the trabecular meshwork and the inner wall of Schlemm's canal. And you see this trabecular strip here, which you can remove later or with the help of forceps or after doing the phacoemulsification. So you see the cleft again post-operatively. Now we have been performing this procedure bang with 25 gauge needle, and it's a very, very cost effective procedure. You just require this 25 gauge needle, and procedure is again the same, that you have to incise the trabecular meshwork. Although I feel it's an incisional thing, it may not be the excisional thing. And this is another patient where you can very easily incise the trabecular meshwork and inner wall of the Schlemm's canal to get this white line or the outer wall of Schlemm's canal. So now coming to GATT, which was initially described by Grover, and it has been done extensively at various centers in India also. And the suture GATT with 50-proline is very, very cost effective, and you can do 360-degree goniotomy or 180-degree. And I would suggest that initially to begin with, you can start with hemi-GATT, and unroofing of the Schlemm's canal is done with 25-gauge needle. And then this mushroom-tipped 50-proline suture is introduced into the Schlemm's canal. And the micro forceps, or the retinal forceps, is used to grasp the suture and advance the suture in counterclockwise direction along with the circumference of Schlemm's canal. So again, you should not meet any resistance here, and it should go along the circumference or arc of the Schlemm's canal very easily. And once you have done whatever you target, 180-degree or 360-degree, once you have done this, you just pull the suture externally and withdraw from the section, and thus incising 180 degrees of TM. So I would suggest that whenever you're doing these angle procedures, if you can demonstrate these fluid wave at the end of the procedure, wherein you see the blanching of vessels here, and you can ensure that you have made a connection between the anterior chamber and the collector channels. So I think it's important to demonstrate this fluid wave. Last one is eye stent, which is made up of surgical grade titanium, and it is heparin coated, and it is self-primed. And this is the initial device, the single device. And now we have this eye stent inject, which comes as 2 eye stents with a pre-loaded injector. And I'll just show you the video. So after visualizing the angle, so you have to retract the sleeve so as to project the trocar, and so trocar has to be, you have to go up to the angle and place the trocar perpendicular to the TM and gently dimple into the trabecular meshwork. And you will get some bleeding here, and push the black trigger button. So bleeding is a good sign, and just move 2 to 3 clock hours away and inject another one. Just 30 seconds.
You have 1 more minute.
Okay. So once you have injected, you just visualize after clearing the blood, and both the stents are in good position. And this one is eye stent, the single device. Again, after doing phaco and visualizing the angle properly, you insert this device into the angle. So first you enter at an angle and then go parallel to the trabecular meshwork. And just check it by tapping on the snorkel that it is well in position, and then complete your IA. And so this is the post-operative positions of the eye stent, and it reduces, because of the paucity of time I couldn't discuss the studies, but there is definitely a scope of mix in the coming years, and there are now heterogeneous range of surgical options with the development of these novel surgical techniques. And we have a chance to tailor our therapy and individualized therapy for a particular patient, especially in mild to moderate glaucomas. However, in Indian scenario, we need to do some RCTs to gather more evidence about the procedures.
Thank you, Dr. Sunita. So our next talk is by Dr. Venkatesh. He's going to talk on future of glaucoma management. So he's going to cover everything from diagnostics, therapeutics, whatever is available and going to be available in the future.
Thank you, Amit. I very carefully prepared not to overlap with all the talks which we had so far. But let's see. So we know the problem and we know early detection is the key. But the current problem is, it's asymptomatic, diagnosed too late, no single most effective screening test. Still, trabeculectomy is the gold standard, not only for glaucoma specialists, but across all other specialties who do glaucoma. And if you see conventionally medications, we have to use daily or twice daily, thrice daily. And just intraocular pressure is kind of unfit to discriminate between a normal and a glaucoma. So that's where I think we are looking at appropriate detection, even related to genetics, and I'll also touch upon some of the interesting things in glaucoma treatment. So when we are talking about detection, I think it's case detection is key, and opportunistic screening is the way to go. Now we'll have to make sure we have better screening strategies. More importantly, we need to see like an ambulatory blood pressure. Once in a while, can we measure their intraocular pressure round the clock to really understand, and also better structure and functional correlation. I mean, that's where this is going to come in a big way. Whether we want or not, we are going to see AI to classify, just to say to refer or not, glaucoma, non-glaucoma. It may be kind of identifying a fast progressor, a slow progressor, or between just a progression and a non-progression in some cases, and also to study risk factors and quality of light. So now we know, most of us know that it can interpret fundus photos already. There are offline ways to do it also. And future, there are a lot of work going on to identify progression, interpretation of OCTs, and also in correlation with visual fields and OCTs. Yesterday I saw an interesting work from the fundus images taken for glaucoma and diabetic retinopathy. They are able to classify the cataract, how much of haziness in the media, and then you can grade cataract, and they have seen cataract patients and it correlates with that. So that kind of validation is going on with machine and deep learning, and also with structure and function correlation. So even at present, we can do all this. We can put everything and you can detect glaucoma and look at progression beautifully now. But I think in the future, when we have more and more clinical data, especially from the high-risk patients, you can have genomic data, you can have lifestyle data, risk factors, medical history, and then you can find out who's got the risk of developing glaucoma. Which is the best management? Is it going to be laser, surgery, or within surgery, which is going to work for him better? We can see the prognosis, and of course even we can see how the surgical success is going to be in a particular patient. So intraocular pressure measurement, there are a lot of interesting things happening, but the future is looking at somewhere can we do 24-hour. I see a lot of work where we are going to club or piggyback with the intraocular lenses, CTRs. So now we have sensors for drug release. Even your steroids will be released from intraocular lens. The haptic will become a releaser. So now we are looking at haptic for fixing a sensor, a CTR with a sensor, which either goes into the sulcus or into the bag, and you can easily measure the intraocular pressure whenever you need, and then that reports can be going to your physician or your treating doctor. Same way it can be in suprachoroidal space. People are working on it. But all these again need some technical expertise and way of application. All this is important. For long years, contact lens has been used in labs, but now it's going to become practice. You will have contact lens sensors where you can have round-the-clock monitoring of intraocular pressure. And my good friend Satyan touched upon this. Virtual reality, not only for visual fields, but to even make your patient understand the vision problems for glaucoma. I saw dozens of posters and papers in ARVO just to make them feel about glaucoma, how the visual defects will be, binocular, uniocular visual deep. So a lot of ways now VR is being exploited in glaucoma purposes. So my good friend Rajal is going to talk about it, but we are going to see again a lot of changes. Now we are finding new genes now. We know pre-existing all these things, but a lot of research is happening to find the new causal genes and the mechanisms for glaucoma. And in future, this is going to help us in gene therapy, which is already there for a lot of conditions, for Leber's and certain kind of RP. But I'm sure we'll have gene therapy for pigmentary glaucoma, primary open-angle glaucomas, and things like that, wherein you can just get rid of all other medications and things like that. So medications, I'm sure you'll be going through all the newer advances. But advances are coming in the way you apply medication. That is where it is very important. Do we need to put 25 microliters, 30 microliters into an eye, which just needs 7 or 8 microliters? That's where these two are going to be there. Again, maybe within a few months you may have eye droppers like this in India, like the nano dropper. No, you can fit it to any bottle, and then it reduces the size. So you can even use it a little longer. We have proven that you don't have to throw a drug after 4 weeks. You can use for 6 weeks, 8 weeks. We have tested and proven, so a lot of evidence is there. And the other one is my good friend Sean Yonchlev's innovation called the iNovia, where there is a jet which goes just 7-8 microliters into your cornea, and they have done several trials to prove it is good, and then it works very well. Then the other part would come not only in neuroprotection, but also nerve regeneration is coming in a big way. You will have people replacing retinal ganglion cells soon. There are several ways people are trying in the form of injections into intravitreal, surgical implants, even drops for regeneration. But the ciliary neurotropic factor, this is a molecule known to promote neuroprotection and regenerations. There are several models in animals and even human models. It's working very well. So we'll find a way to surgically implant this CNTF to kind of do the nerve generation. The other area is the pluripotent stem cells. I'm sure it will be boring, but it kind of drives the future glaucoma treatment. You can just remember that. These can change the damaged trabecular meshwork cells, and you can see a lot of work happening in this and a lot of research publications and posters happening at R1 and other big meetings. This is a nice innovation which is already there. A lot of people find it difficult to do an SLT with a gonio, they're doing it in the right place. But now you have something which is non-contact, which is automated, where you don't have to put a lens and you do directly. This is really helping, and this has actually driven a lot of SLTs in Western world now. And already you have Durista, you'll have a lot of sustained release medication, so that they're going to release medications for next 3 months, 6 months. So once in a while you implant it and then forget the patient of daily usage, which is such a big headache for some of these patients. So beautifully, Madam described the several techniques. There are so many techniques, but the angle surgeries are coming in a big way, so that you have space for future surgeries. You can do trab, you can do tube, you can do Zen. But if you're going to do anything inside the angle, your conjunctiva is going to be virgin. So there are a lot of techniques which have come and go. CyPass is gone, but Sean is working on a different implant which goes, and he says it's better than CyPass. But there are implants which will come and go. But again, surgical skill, talent, tremors, everything matter here. So that's where I saw this recently. And this is also going to come in a big way. No, you're not looking at big robots to do surgery. No, they're going to be very fine robots which will be there on your table or in your operating room. And this is one thing, again, a company called iNovia. I had a chance to try it a couple of months back when I was in ASCRS. So beautifully they are doing angle surgery, because you need a very good control when you're putting an implant like an eye stent or a hydrus into the Schlemm's canal. See, that is very important. Whatever be the tremors in our hands and the microsurgery when we do into the angle really needs a very good control. And that's where you're going to see a big future for eye robotics in angle surgery. With this, I would like to say the future is not only bright, but also near to us. Thank you.
So very nicely summed up right from the future, all the future developments which are going to come in around the world. So nicely summed up. So we'll take the next talk on glaucoma genetics by Dr. Rajal Parikh. So I'm sure we are, all our esteemed panel chairpersons are there. There are enough time to discuss each and every topic.
So I would thank AIOC for the invitation. So I'll be talking about, can we start the?
Yeah, Rajal, you can,
yeah. So I'll be talking about glaucoma and genetics. So I have tried to divide my talk into 3 parts. So in first part, I'll cover the genetic association. In second part, the role of genetic screening, whether it would be really useful in future. And third, gene therapy. Now, if you look, this is theoretically speaking, the genomic analysis would be the best way to predict that someone genetically is predisposed. Of course, this is the future. I'm not talking that this is reality at this point in time. Now, when we see the disease, there are two ways. One is the single gene disease and other is complex disorder. That means multiple gene involved. Unfortunately, glaucoma comes in the second category. It's not a single gene disorder. If there's a single gene disorder, then the gene therapy would have been much easier to identify and start. If you look the literature, there are lots and lots of gene loci has been identified, including the chromosome. I'm not going to go in detail because there are multiple. Otherwise, it would just take 10 minutes only to talk about the association, and that is not the part I want to talk about. So basically, we have autosomal dominant inheritance. We have autosomal recessive inheritance. I mean, just remember we have learned all these things in MBBS. Now, if you look the POAG genes, and I just try to cover a little bit, we have myocilin, we have optineurin, TBK1. Now, the mutation, the myocil are associated with 3 to 4% only in POAG with increased intraocular pressure. And if you look optineurin and TBK1, they are associated with only 1 to 3% of open angle glaucoma with normal, that means normal tension glaucoma. Only 4%, not less than that. And so genetic testing, if you do in general for all these, and there are kits available in abroad, I'm sure it will be available in India also. It's not useful because it identifies only 3% of the population with glaucoma. However, if the research has found that the myocil, there are certain variants are associated with very aggressive glaucoma which responds to early surgery. So the research is trying to identify whether which group and whether we can do the testing to identify this group. The research is going on, and this is at this point in time only at the research level, not as a clinical practice level. If you look exfoliation, there are various LOX1 gene, the variants have been identified. I'm not going to go again talk about it. There are protective rare variants also have been identified. If you look, this is from the multi-center study. One of the center was Shankar Netralaya. They identified 3 loci susceptible for the primary angle closure glaucoma. So we have lots and lots of study going on to identify the loci, and the future is interesting. But at this point in time, my question, this is more relevant in day-to-day practice, whether we should use these genetic, what we know in research in clinical practice. So we have to understand that dominant inheritance has a 50% offspring chances of having the disease going to the offspring, whereas recessive has 1 in 4. So this is the basic thing, So when you do a pedigree charting, and this is very important, then you come to know whether it's autosomal dominant or recessive pattern. Now, for the early onset glaucoma, that is juvenile open angle glaucoma, congenital glaucoma, the association is approximately 20% for the various genes like myocil, PTEX2, FOXC1, so 20%. Now I will just come to next what American Academy, because they come with the guideline that how to use this. So the American Academy guideline says that only if he's going to impact, and this is a basic thing, that only if he's going to impact the clinical practice, then we should use that test. So genetic testing also come in the same pattern. So if the patient with the parents with juvenile open angle glaucoma, congenital glaucoma, it may be useful. POAG, the late onset glaucoma at this point in time is definitely not useful. So, and I just try to give some of the example I borrowed from Ronnie. So this was the one patient with the atypical axon-filled rigor, and I had sent it to Ronnie because they have a much better setup than my private practice. So we wanted to differentiate between axon-filled rigor, whether it's mutation or primary congenital glaucoma. And why it makes difference? Because if the patient has a axon-filled rigor mutation, then chances of going into the offspring is nearly 50%, as opposed to primary congenital glaucoma is little lesser. The same thing, this was one of his patient, and he had given me the slide that the patient father was juvenile open angle glaucoma, 3 kids, they did the mutation study, and that one kid had mutation for the juvenile open angle glaucoma. So that kid should be examined more thoroughly, and other 2 kids can be, we need not examine very aggressively. So this is how you can use, but again, the bottom line is that at this point in time, the genetic screening is basically should be used more for the research purpose rather than day-to-day clinic purpose for the screening. And then I will come to my last part, gene therapy, this is something going to be interesting, because we know medication, we know surgery, everything has limitation, and we also know that there are lots of the mutations happening. So if we can take care of the mutation, the gene, the problem, then we can rectify the glaucoma to a certain extent in that particular patient. So this is going to be interesting. So what is gene therapy? So by definition, the medical approach that treats or prevents the disease by correcting the underlying genetic problem. Now there are two methods. One is gene transfer and other is genomic editing. So I'll try to cover a little bit of these two aspects. So gene transfer, which is going on for some long time. So basically it introduced the new genetic material by various vector, and usually there is various viral vectors are used. Now recently the nanoparticle, the nanotechnology also has come into play to use as a vector. And the third is we can introduce the direct full DNA. So it alters the gene, causes the necessary protein to be faulty or missing. Gene transfer therapy does edits that, and it corrects the gene problem and the protein malfunction. So this is one example. This is not from the glaucoma, but basically you have a viral vector and you add that new gene which you want to go into the host cell. So at the same time you also edit the wrong properties of the viral DNA, because you don't want other diseases transferring, because we also use the HIV virus also for the as a vector. So you edit that, you insert into the host cells DNA. So by either you can do intracameral injections, you can do intravitreal injection if you are targeting retinal cells, retinal ganglion cells. So it gets incorporated into the messenger RNA, which goes and replicates into the DNA and sells the faulty DNA. This is how the gene transfer therapy works. Now editing means it does the partial editing, only focuses on the portion which is wrong or faulty. Now what are the delivery system and target issues available in research at this point in time? We have 6 delivery system, namely adenoviral associated, LV, that means it takes care of the feline immunodeficiency virus and human immunodeficiency virus, HSV. Then we have a new liposomes, that is nanoparticle, and full DNA. These are the 6 delivery system available. We have 2 way. One is anterior delivery system, that is we are targeting the trabecular meshworks, and we have posterior delivery system, that means it targets the retinal ganglion cells by intravitreal injections. So here in anterior segment, basically where it works on trabecular meshwork, all the research animal models have found that LV, that is working on feline immunodeficiency virus or HIV virus, have a better chance. And one of the studies have shown that and I will quote some of the Kaufman has done lots of research on the gene therapy, and I'll give a couple of examples. And where the posterior segment delivery system is concerned, the intravenous delivery, usually it works by the adenoviral, that works much better, and some of the studies have shown that one intravitreal injection in the rat, it results up to the 72% of the transaction efficiency, and it works by the expressing up to the 3 to 4 months. Now how it translates into clinical practice is long way to go, but the research is going on. So this is one of the example where they had used the feline virus for the trabecular meshwork to do increase the IOP reduction ability. So this is a Kaufman, as I mentioned, feline. What they had done was to use the lentivirus gene cassette for the prostaglandin biosynthesis, which increases the IOP reduction ability, and one injection had effect for the 5 months. They also had done, what you can do is that because your host DNA has a enzyme which try to degrade these molecules. So what we can do when you inject the gene, we also can disable these proteomeres which can degrade the particles. So they had done the both way, and this is with the proteasome blocking agents, and you can see that the collateral channels works much better and for longer time. The other models which works on the IOP regulation trabecular meshwork using the urokinase gene expression, there are lots and lots of data. I have just given 2 examples because in 10 minutes I cannot cover everything. So to conclude, the glaucoma is complex gene mechanism, so is difficult to identify by one gene, one therapy is not possible. The second, screening is limited at this point in time. It should be restricted only for a very selective group of certain juvenile open angle glaucoma and congenital glaucoma. The mass screening is definitely not going to be useful just like mass screening what we are talking about the diagnostic test. And third, the gene therapy has lots and lots of potential. It would be for both IOP, reduction, regulation by trabecular meshwork, and ganglion cell protection by intravitreal injections. Thank you.
Thank you, Dr. Rajal. So we have finished all our talks on time. Now I invite the chairpersons to comment on the talk and give their views for the topics covered. So the first topic was current and future trends in application of angle imaging. Dr. Vijay ma'am, you have been in, Shankar Netralaya had been doing these studies, and I think one of your consultants' PhD topic was about angle imaging. So can you give some inputs about this? I'll just give you my.
See, technology is something that will keep evolving, and we have to keep applying in our clinical practice. I always tell people the day we cannot incorporate the new technology into the practice, that is the time for us to go home. So that is how I look at it. I think we have to continue to use it. And so Shushmita has put in very nicely, yes, there is a definite role for imaging in using in our practice, but you should always keep the limitation that is associated with it. And I want to re-emphasize again, yes, you do imaging of the anti-segment, but don't forget to do the gonioscopy. The information you get with the gonioscopy in terms of the synechiae or the pigmentation or the new vessels, any other abnormality, you will never get with your imaging. So imaging is a tool, you use it. We all the time we use both UBM and ASOCT. At the same time we do in every case a gonioscopy. That is what I want to emphasize as a take-home message. Don't fear technology, use technology appropriately in your clinical practice.
Argesh sir, what about your views?
Yeah, first of all, I congratulate all the speakers for the wonderful presentation about the recent latest future of glaucoma diagnosis and therapy, and also I completely agree with Vijay what he told. We cannot completely rely on the recent all these gadgets in evaluating the angle parameters, but nothing will replace at this point of time. Still the gonioscopy is the gold standard, but we should, as pointed out, we cannot ignore the recent developments, because in future we don't know, because sometimes we can get a 360-degree evaluation of the, we can see at a one shot. That also is going to come, but it has got certain roles, so anti-segment OCT or UBM. Definitely they have got a role.
So I would like to ask the panel, yes, Harshal.
Yeah, just another thing that definitely it helps us to identify sometimes very unusual situations. So we just described one of the newest mechanisms for silicon oil induced glaucoma. But if we did not have the ASOCT over there, we would not have been able to identify how the oil had come forward from the periphery and pressed the iris forward. So sometimes it really helps in identifying what it is. And beyond that, in private practice, when you have decided by your gonioscopy that you have to do a peripheral iridotomy, the patient is reluctant, you show them these images and they are very, very convinced.
So one thing I would like to ask to the chairperson is role of ASOCT in today's scenario in our country. When we go into the trade, we see so many companies are coming up and incorporating the ASOCT module in their equipments, whether it is with the NCT or whether it's a combo of AS and posterior segment OCT. And today we saw a machine in the Remedio. They have everything in one machine, right from anterior to posterior. So how important ASOCT has affected your practice?
Well, ASOCT has a huge role actually in practice today. In glaucoma, yeah, we see the more superficial things in ASOCT, which the deeper structures and stuff we see with the UBM. But you know, when you're doing a femtosecond laser, you see a live ASOCT when you're docking your patient with that LPI. So I think ASOCT has a huge role, maybe not so much in glaucoma, but even then, like Sir said, it does have a role in certain situations in glaucoma. But in cataract, I think it has a huge role. When I see that live OCT going on when I'm docking my patient, it's really mesmerizing that I can actually see what's actually going on inside the eye while you are operating on a patient.
So how many of you all have been using the intra-op OCT in glaucoma surgeries? I mean, any experiences of intra-op OCT in glaucoma surgeries?
Exactly.
So
I have tried in 2 patients and I never found it to be useful in the glaucoma surgery. No, not for me. But yes, it is a very important tool. I am using it a lot in my patients, not only for diagnostic, post-operative blab studies. That also is very helpful. The ASOCT, in early post-op, you can evaluate your blab in vivo. So I'm not shy of using multiple gadgets. It adds to the knowledge.
Yeah, that's true. As ma'am told, as technology is advancing, you need to incorporate. So intra-op OCT, the reason I was asking is people are investing in these machines, especially it helps in the build-up of the cataract practice. So every cataract practice has a glaucoma surgeon also with him. So as a glaucoma surgeon, how important it can be a tool for us in our glaucoma surgeries, that's what I wanted to mean. Because younger generation, especially when we are doing traps, we know the plane where we are entering, how much is the opening we have made, is it adequate? I mean, there are a lot of Pandora's box which opens up if you get a new gadget and you are playing with it. So that's the reason I wanted to ask, what's the experience of the intra-op OCT? Because when this machine was in AIIMS, we had a lot of discussion about what is being happening. So Pandor sir, anything or your views on this?
We are not using. We have intra-op OCT with us, but we are not using it for glaucoma surgery. Because the reason is the same, because we don't really feel the need that it will improve. But maybe there are things which we don't yet know, and because things are evolving, the techniques is evolving, and also the surgical skills. But the ASOCT we find useful perhaps more in pediatric glaucoma rather than adult glaucoma, because where the angle, the cornea is a little hazy, and the angle anatomy really, you want to see what's happening behind. I think there it gives you a good glimpse of what's happening inside the eye. Other than that, I think there's been a good discussion on angle closure and other things, but I think we are still at the Gonoscope is still the technique which is to be learned.
Yeah, Vijay ma'am.
Just I want to emphasize
Mic, please. Use the
about the role of ASOCT. I don't deny the importance or usefulness of ASOCT in our day-to-day practice, but we have to think as a whole, because other people, they should not go with the wrong message that ASOCT is a must for glaucoma practice. It's not. We are all from big institutes, so we can afford to have all these gadgets. But common people, those who are practicing in suburban, rural area, it's very, very difficult. So if they do good gonioscopy, there is much more sufficient.
I just want to make a comment. So when the industry is offering technology, because it has become easier for them to incorporate more and more, take it. There is nothing wrong in taking if it comes to you free of cost, more than what they have quoted. So what I keep telling all the students, youngsters working with me, if you advise in investigations, be clear in mind what you want out of the investigations. If you are not sure what you want, don't advise the investigation.
True, ma'am.
Just Amit, we have 3 devices to compare. One is the anterior segment OCT, other is the UBM, and third is the automated gonioscope. And all these 3 are different. And I'm sure that everyone would agree that UBM has a role to play in glaucoma practice. We cannot avoid if you are doing the subspecialty glaucoma practice. ASOCT, yes, it is little dicey, and you don't get that much of information what you can get with the UBM. And for automated gonioscope, I would say that yes, probably it's a future. As Dr. Vijaya has said earlier, that technology is evolving, and we have to accept it. And I'm sure that it would evolve, and it will come as a non-contact automated gonioscope sooner rather than later.
Thank you. We go to the next question, next topic, that is the role of advancements in perimetry in today's practice. So there are a lot of advancements in perimetry, but the most important thing is the cost of the machine which is involved, and for a private practitioner, the break-even is not achieved at all. But still, we do say that that's a gold standard and we should have a perimetry. So my question to the panel is, virtual perimetry, cost-wise, is more cheaper compared to the Humphreys or the Octopus. So what is your stand for a private practitioner? Can this virtual perimetry be a substitute to start their glaucoma practice? Anybody from the panel? Yeah, Vijay ma'am, yeah.
Sorry, I'm sitting at the wrong place. And what I want to say is that there is something called diagnosis and the progression. For the diagnosis, you can use any of those tools because it tells you where the visual field defect is. But they cannot offer to follow up the patient. So that is the basic difference. So this kind of a discussion about using the machine, private practitioner using the machine, we had a lot of discussion for many years in our GSA meetings. I think that's where your group practice comes into place. You have a machine that can be used by more than one person, and there is no shortcuts. You have to keep updating your software.
Ma'am, we can get the progression on these virtual perimeters also.
And that is,
but you don't get the statistical analysis to
yes.
say how the trend, how the event based
I think that's a technology improvement.
That
Dr.
has become the
Venkatesh,
standard of care for the glaucoma
progression.
As Vijaya said, that is the Indore model. I always quote the Indore model because in Indore, one practitioner told me that 10 of us have got together and that we are able to spend less money. But
Indore is famous for group practice. We have a lot of group practice people and everything is sustained.
Yeah, so we did something in the MRF fields, and like Vijay rightly said, you can detect this thing. It's only you can have an iPad, which most of the people have. It's very cheap, 30,000-40,000, and in 200 rupees you'll get the field through the net, and you can do it for that much in one patient. But again, the follow-up is not good. The progression detection is not that adequate. So that is the trick.
I think the technology is still evolving, because I think if you look at the alternative parameters, they have come a long way. And now we are accepting that they could be used for initial diagnosis. It would be a matter of time when we start accepting that they could be used for progression as well, because we are used so much for a particular platform. We depend a lot on that platform for progression because we understand that better. But this newer technology we don't understand as much as we understand the other one. And the only thing someone has to do is to come up with the software which is as good as the software which drives the other platforms. Only issue is the validation, because we have platforms, we have the software, but that's not yet validated the way the known platforms are validated. So I think it's a matter of time. I think a lot of progress is happening, and
the
there
other
may be a point of time when we will be using that more often. Yeah.
The other side is that the COVID era has taught us that how useful these equipments are. You just take the AVA and go to the patient and get the perimetry done, and then you compare whatsoever. You have a database available in your hospital. So, and for non-ambulatory patient, who cannot come to the hospital, you can do that. Yeah. And the third is for obviously screening purposes.
So out of all these questions and remarks which were given by our chairperson, I want Dr. Satyan sir and Dr. Venkatesh sir to give a brief comment, because they have been into the research of these things. So a quick comment from both of you all to answer all the queries which is put up by the panel.
Yeah, we are a little younger generation than them. So I think we have a lot of restrictions. I feel it is a subjective test. We think by doing it in a Humphrey or in Octopus, we get a better results, but which is not really truth. The virtual perimeters give a much easier testing for the patient. That is what we are every day we are looking at. Can we give something easier for the patient? I kind of started accepting the virtual perimetry is much more easier for the patient to do, and the results are even better to an extent at least. At least we haven't completed all our detailing, but I feel it's just a matter of time. It is going to be in And of course, we do have the progression analysis in the newer ones. It is the software upgrades. I think it is just a matter of us accepting it in a recent future, I think. It's going to be, definitely will be there. Yeah.
So thank you, sir.
Is the progression validated?
Yes.
It is?
It is.
But it comes on the thermal paper, which you cannot even preserve for 15 days.
All your NCT values, auto-ref values, everything has been thermal paper, and we are taking it and feeding it. Which one, madam?
Does it have a normative data to assess the
Yes, madam. Now they are all bringing out the normative data. So if you really look at the OCTs, most of the OCTs are not having Indian normative data. It is all, most of them are the European normative data which we have. But we are all accepting that, and then we are doing it, including the Heidelberg. So we really don't have the Indian normative data in most of the equipments.
Thank you, sir. So going to the next topic of Dr. Sushma, OCTA GCC. Okay, GCC has been there. We have been accepting it in our practice. How OCTA has changed your glaucoma practice? Anybody from the chairperson? How OCTA has changed your glaucoma practice?
I don't think really it has changed, because we have the OCTA for over a year now, and the disc perfusion that it gives, we were discussing in our IC with Sushma yesterday, is that there is no cutting, bar to it. What is the cutoff line for your perfusion of the disc that it gives? Because we really don't know whether a 44.6 or a 56.1 is validated, because the company or the manufacturer does not give any kind of a cut line to that. So basically it does not actually change, except that over a period of time, maybe 6 months or so, if you repeat 2 OCTs of OCT angiography and you see one has a 44.1 and the other has a 60 point something, then maybe you could come to some conclusion that this disc perfusion is better or worse than the previous one. But otherwise, apart from that, nothing actually for glaucoma.
I think the one thing we have found is that OCTA is very sensitive to testing conditions. That means if you are doing OCTA today and is showing you something, you repeat it after 1 month or 2 months, it may come up with a very different results. The image acquisition has to be very, very accurate in both the situations. Even if a little bit of brightness or intensity goes up or down, your values, the index that we calculated, goes up and down. So you don't know whether this is happening because of perfusion change or just because of the brightness change. So I think I'm sure with time these things are going to develop, and they'll find some ways to normalize the data, normalize the images. But I think it's another tool, because we don't actually have any good tool to tell you the vascular, the vascular, supply of the optic nerve or on the retina. So this is something that we have now, and we do use it. But I think where there is a change in the practice, I don't think it has really changed in that sense.
Ma'am, for early diagnosis of glaucoma, how important is OCTA according to you?
No, I think we are having we had the same kind of debate when OCT was introduced, okay? And the technology has evolved. It has become a standard of care now. We all use OCT in our clinical practice. As Pandav said, I think when you repeat it 3 times, you get 3 different things. That is mainly because at present point of time, the technology depends upon the motion. So the motion artifacts comes into a picture in a huge way. So it's question of time before it will change. So wait for some more time before you bring in OCTA into your normal clinical practice. Probably the institutes have it, they use it for the clinical research. There is nothing wrong in correlating and seeing what is happening with it. That's how we learn and we progress. At present point of time, I don't see a role for it in our routine clinical
So that's
practice.
how, madam, when OCT was introduced, we had a big question mark when they should tell us pre-perimetric glaucoma, and now pre-perimetric glaucoma is accepted and we are treating based on that. So now OCTA has come, and I think more work on that, and it is going to change our practice because technology is evolving. So coming to the mixed procedure, the role of mix in India, that has always been my question, and I and Dr. Venkatesh sir, we always talk about mix in India. So Dr. Sunita has shared a lot of good information. So what is your say on mix, Harsh sir?
The hard fact is that, like Venkatesh and Sunita clearly defined, the ultimate surgery later on is going to be in the angle. We are all fed up of doing trabs and seeing its complications later. And actually the chap who came and taught me the eye stent, he threatened me that if you don't learn, I'll go to the cataract surgeon. They are very happy doing newer things, and you bloody old people, you don't want to. So I was forced to learn literally. And it has a good learning curve, there's no doubt. But if I can learn, then every one of you youngsters can learn. Please, like Sunita said, tilt your microscope, tilt the patient the other way. 6,000-7,000 rupees ka, 7,000 rupees you get a care lens. Put it over there, keep seeing the angle, put your Sinski inside after you have finished the cataract surgery, touch the angle, see the angle. The ultimate surgeries, all these surgeries would be far superior. We are getting newer and newer interventions, and we did a couple of eye stent injects, and they are doing fine. The costing is very much, but if the insurance pays, what the hell. But sooner or later, all the other surgeries which are coming are in the angle. So you have to learn this, that is the bottom line.
So angle surgeries are evolving, and they are going to be the standard of care, I feel. And as all our glaucoma specialists used to advise that you need to do gonioscopy, you need to practice gonioscopy, you need to apply gonioscope on all your patients. So today the standard of care will be you need to buy a direct gonio lens, you need to apply it on all your cataract patients, you need to start practicing right now, so that what I said, otherwise you will be left behind if you are not able to do a direct gonioscope. We have one more minute. I'll finish on time, don't worry. So, okay. A quick comment about the other talks, role of mix in angle closure. Well, I just need one comment from anybody. Any role of mix in angle closure disease, you think?
No. Basically, it has to have an open angle most of the time.
No.
But
No.
yes.
Yeah, we'll take one, madam, one comment from your side. Whatever you want to say. Role of mix in angle closure. Come to the podium. Yeah.
Use the microphone. Here. Use this.
No.
She showed yesterday.
Worldwide, eye stent is most often used by the cataract surgeon, then the glaucoma.
Yeah.
No, we've started, since we have a huge load of PSCG, just a quick comment, ma'am, that it works in PSCG as well. We've been doing bang in PSCG, and it's possible to open up, because even if it's PSCG, the entire 360 degrees is not closed. Yeah. So you have a bit of trabecular meshwork, you engage it in, strip it off, it works well.
And as Harsha said,
after doing PA,
yes, of course, after laser iridotomy, only if combining with cataract surgery, then it works.
As Harsha said, mix is expensive. No, bang, it can be very cheap, but you need to practice your direct gonioscope. And the last question, what Dr. Venkateswar mentioned, iRobot. So where are we if iRobot comes? Where do we stand?
We are very happy. We'll be very happy, not doing anything.
So I will be retired and gone.
Somebody has to operate the robot, so we will be the man behind the machine. So we are still there. So it's so nice of all of you all to finish the talks on time. We had a good discussion, ample amount, and I'm thankful to all my chairpersons, my seniors, my mentors, my teachers, the founders of our society, and all the respected speakers who have been doing great work in the fields which have been given to them. So I quickly invite for a group photograph, and then we hand over the hall to you all.
Yeah.